Good day, everyone. My name is Caitlin Frisbee, and I'm a postdoctoral researcher at the University of Pretoria in South Africa. Today, I will be presenting a research article titled Digital Technologies for Community Health Worker Facilitated Hearing Assessment in Low-Resource Settings, a feasibility study. Before I begin, I would like to acknowledge my various collaborators from across the globe, as well as the valuable funders who made this research project possible. I would also like to disclose that several of my co-authors are affiliated with the HEARX group. The funders of this project included the World Health Organization and the NIH. As we all know, the prevalence of hearing loss is high globally. However, there is a higher prevalence of hearing loss in low and middle income settings. This is due to the limited availability of hearing healthcare professionals, with some countries in Africa having less than one audiologist per million persons. In addition to the limited availability of healthcare professionals, there are also high costs associated with traditional service delivery models that are usually centralized and make use of very expensive equipment. In response to these disparities, the World Health Organization has recommended strategies to address this inaccessibility. These include task shifting hearing healthcare services to community healthcare workers who can facilitate these services through the use of innovative digital technologies. In light of these recommendations, the World Health Organization has recently developed an end-to-end service delivery protocol to provide hearing aid service delivery in low and middle income settings facilitated by community healthcare workers. This research project therefore aimed to evaluate the feasibility of community healthcare worker facilitated hearing care enabled by digital technologies for e-assessment, hearing testing, and telehealth support in low and middle income settings. This feasibility study was implemented in 3 low-income communities in South Africa and facilitated by 3 community healthcare workers. Adults with self-reported hearing loss were recruited, and the WHO hearing aid service delivery protocol was followed. The premise of this protocol is that all services should happen in a single session. It starts off with a community healthcare worker facilitating a basic profile, e-examination, and otoscopy. If no abnormalities are detected, air conduction audiometry is then conducted. If a moderately severe, or severe hearing loss is detected, these community members are then recommended for a hearing aid fitting. The basic profile and otoscopy included a red flag questionnaire that was developed by the WHO and otoscopy. For this, we used the HearScope, which has been developed by the HEARX group. This is a digital video otoscope that has artificial intelligence classification support and provides the community healthcare worker with a classification, so they don't need to do any interpretation themselves. Categories included normal, wax obstruction, perforation, abnormal, and could not classify. A telehealth WhatsApp support group was created, and if an abnormal or could not classify classification was obtained, the community healthcare workers were instructed to contact the program manager via this WhatsApp group. All participant results are stored securely on a cloud database. Community healthcare workers posted the participants' alphanumerical codes on this group, and the program managers, who consisted of audiologists as well as an ENT, could remotely review the results and provide community healthcare workers advice on the next steps. In terms of audiometry, pure tone air conduction audiometry was conducted at 500, 1000, 2000, and 4000 Hz. A validated mobile automated audiometer was used, namely the HearTest, with calibrated headphones. All of these innovative mHealth tools make use of a cloud-based data management system. This allows for program managers to remotely review test results as well as various quality control metrics. In terms of the method, we first wanted to determine the accuracy of the AI classification support. Adults aged 18 years and above were recruited and underwent video otoscopy facilitated by the community healthcare workers. A qualified ENT then blindly reviewed and classified the images, and this correspondence was determined. Once the AI accuracy had been determined, the protocol was then implemented on a new cohort of adult community members. In terms of the AI classification accuracy, 212 adults were recruited and 89.2% accuracy was obtained compared to ENT classification. The agreement between classifications was high and ranged from 71.4% all the way to 100%. An additional 143 captured images were described by AI as could not classify. Here, there was only a 28.7% agreement with ENT diagnosis. However, these disagreements are largely due to images being out of focus, insufficient lighting, or a pathology that could not be sensitively classified by the AI. Once the AI classification was deemed accurate, we then proceeded with the service delivery protocol. 166 adults were recruited, and participants' ages ranged from 21 all the way to 100, with a mean age of 73.6. The majority of participants were female. Of the additional 166 participants recruited, 163 completed otoscopy. Reasons for 3 not receiving the otoscopy included 2 participants who presented with active drainage and 1 instance of technical difficulties with the otoscope. Of the 326 ears that underwent video otoscopy, normal was the most common AI classification. 161 participants had their hearing tested. 5 did not undergo a hearing assessment, of which 2 presented with ear infections with active drainage, 2 presented with occluding earwax and opted for wax removal before testing, and the final participant refused to be tested. Of those tested, 77.6% presented with a mild or moderate degree of hearing loss. The average duration of the hearing assessment was 6 minutes and 41 seconds and ranged from 2.58 to 21.1 minutes. 30 participants presented with quality control concerns in either one or both ears. Thus, a total of 36 concerns were highlighted. 5 of these concerns were related to environmental noise that may have exceeded the maximum permissible ambient noise levels. However, none of these concerns were greater than 5 dB, and the remaining 31 concerns were related to test-retest reliability. The community healthcare workers made use of the WhatsApp support group 22 times. 19 of these occasions were due to abnormal or could not classify otoscopy results. Of these 19 instances, 12 were described as normal by the WhatsApp support group, and the remaining 7 were referred for further treatment at a local hospital. The remaining 3 queries were related to red flags. 2 of these involved ear infections, and the final red flag was related to asymmetry. The community healthcare workers responded positively to the support group assistance. However, 2 community healthcare workers reported that when asking for advice, sometimes they would only receive feedback hours later once they had already moved on to a different community member or testing venue. In terms of recommendations for improvement, we recommend expanding the AI datasets to include a broad range of ear pathologies to improve classification accuracy. We also recommend integrating hybrid solutions in terms of telehealth support, where synchronous consultations can be arranged in urgent cases with asynchronous batch reviews for routine assessments. In conclusion, community healthcare worker delivered hearing healthcare using digital technologies is feasible, and this can expand access to care in low and middle income settings. Success, however, does require comprehensive community healthcare worker training, quality control, and hybrid telehealth models. Digital solutions offer a viable path to scalable, equitable hearing healthcare. Thank you very much for your time and attention. You are welcome to contact me if you have any questions.